is on. Cool. Thank you all so much for coming out this evening. I really appreciate y'all coming to hear a little bit about cancer care in Rwanda and discuss global oncology with us. I'm David Shull. I'm a fourth-year medical student here at Harvard, going into pediatrics. And I'm also a part of the Students for Go initiative, which is an offshoot of the larger Go initiative. I think a lot of you in the audience already know a little bit about Go or Students for Go, and often many of you are actually involved. If you're not and you're interested in getting involved, certainly approach myself. There's a couple other students who are involved who are here as well, and you can find us here after. We'd love to chat with you about projects. I'd also really like to extend a huge thanks to all the other students who are on Students for Global Oncology and helped organize this and get food and get this all set up. It's really been great that we can have this case seminar series. The title of our case tonight is Treating Cancer in Rural Rwanda, Delivery of Chemotherapy at Butaro Hospital. And I'm going to be giving this with Marcia Brown, who is a medical oncologist, specializing in breast cancer, works at Mass General Hospital, and also does general oncology at National Hospital. And Lori Boswell, who is Vice President of Nursing at Dana-Farber and Director of Clinical Services, also does a lot with the satellite sites, EMR, and is now working at the Center for Global Health and Medicine at the Dana-Farber. And Marcia was in Rwanda for 2 months this winter, and Lori was there for 3 months. And so we actually all fortunately overlapped together at the hospital. And so we'll be telling you about our time there. To give you a little bit of an overview of what we're going to be talking about tonight, I'm going to start off giving just a little bit of background about Rwanda, health in Rwanda, and then how the Cancer Center was formed there. And then Marcia is going to talk a little bit about how we actually think about treating cancer in this setting, how we set up the center, and actually thought about delivering this care. And then for the last part, Lori is going to tell you about how this care is actually delivered on the ground and take you through this in the eyes of Gilbert, who is our charge nurse at the oncology ward. And so there'll be a lot of pictures and kind of a story, and you'll get a feel for what it's like working there, basically a day on the oncology ward. And this should be interactive, so feel free to interrupt us at any time, ask questions if you have thoughts. We'd love to hear. So to get started, I think a lot of you already know a fair amount about Rwanda, but just a little bit about the context. Rwanda is a small country in Central Africa. It's landlocked. It's bordered by Uganda, the Democratic Republic of Congo, Burundi, and Tanzania. The capital is Kigali, located in the middle of the country. It's a very mountainous, hilly country. I think it's referred to as the land of 1,000 hills. A vast underestimate, I think. And Partners in Health has partnered with the Rwandan government to work in 3 different districts in Rwanda. I'll come back to this, but the first 2 are in the eastern province here. This is Southern Kayanza district and Karehe district, and then the hospital where we worked is Butaro Hospital up in the north, and that's in Burera district. I'll come back to those a little bit later. I'm going to talk just very, very briefly about the history of Rwanda. I think most people just associate Rwanda with the genocide, so I wanted to at least touch on this. Rwanda, sort of as we know it now, with the borders it has now, was formed in the Berlin Conference in 1884. Of course, there were already people living in Rwanda. There was a kingdom in Rwanda prior to this time. And there were 2 dominant groups, the Hutus and the Tutsis. But it was formed as a German colony, and then after World War I became a Belgian colony. And those colonies ruled through having a king. The Tutsi government was set up. And then in 1959, violence began to erupt between the 2 groups and the colonizers. And in 1962, an independent Hutu-run state was brought into existence. There was intermittent violence between this time and 1994 when the genocide occurred. I think a lot of you know about the genocide. Between 800,000 and 1 million Tutsis and moderate Hutus were killed. Since that time, there's been a period of relative stability, reconciliation, and rebuilding. And really, at the time of the genocide, the infrastructure in the country was decimated. But for those of you who've been there recently, it's really remarkable how far the country has come and how much has been rebuilt, including the healthcare system. And I think the biggest exports right now are probably coffee and tea, but there's a growing tourist industry. one of two places in the world we can safely see the mountain gorillas. And there's also golden monkeys, which is another endangered species a lot of people go to see there. In terms of their health indicators, Rwanda is still considered sort of below average in sub-Saharan Africa, although has made tremendous progress in the last 10 to 15 years. It's a country of 10 million people. Geographically, it's about the size of Maryland, and so if you actually compare it to Maryland, the number of people per square mile is about double that of Maryland. So it's actually maybe one of the most densely populated countries in Africa. Life expectancy for males and females is 58 and 61, and you compare this to the US numbers. Under 5 mortality is listed as 54 by the WHO and 91 by UNICEF, probably somewhere between there. The average in sub-Saharan Africa is about 70 or 77. And the health expenditure per capita is $121. And this has actually come way up in the last 10 to 15 years. The total health expenditure as a percentage of GDP is 10.5. This is a picture of Fabrice and his mom. He's one of the patients who was just finishing treatment when we were in Rwanda and actually talked to Lori and I for a long time about his story. It was sort of funny. We asked him if we could interview him and hear about his experience getting cancer care. And his mom sort of laughed and said, you know, the hospital is dedicated. I told my story to President Clinton. I can probably talk to you. And they actually did. Clinton came for the hospital opening. In terms of the healthcare infrastructure, Rwanda has a nationalized multi-tier healthcare system. This is a picture of the health center next to Butaro Hospital, where a lot of patients come for ambulatory visits. Throughout the country, they have about 48 district hospitals. They have over 440 health centers, which are dispersed throughout the country and designed so that patients shouldn't have to walk more than about an hour to get to the closest facility. There's 4 referral hospitals in the country, 3 located in Kigali and 1's located in the southern part of the country. And to pay for it, it's a state-paid system predominantly, with also a social insurance system called Mutual. And so most of the patients we saw had Mutual insurance. In 2010, they said about 90% of people in Rwanda were covered under Mutual. And essentially, people pay about $6 per year into that, and then they pay 10% of their costs when they go to the health center or to the hospital. And this is still substantial for a lot of patients, so there's a sliding scale system depending on your level of income. In terms of human resources, Rwanda has 1 medical school, has 8 nursing schools, there's a dental school and a public health school. They currently have about 470 general practitioners, and these are doctors that get 6 years of training after secondary school, followed by 1 year of internship, and then they'll usually go practice at a place like Butaro Hospital before they do a residency like we would in the US. There's 191 specialists. The majority of those are actually Rwandan-born specialists, and about 6,600 nurses, which may sound like a lot, but it's not a whole lot of nurses for 10 million people. And they're mostly A2 level, which is the base level of nursing training they have in Rwanda. So Partners in Health came to work in Rwanda at the request of the Rwandan government and the Clinton Foundation in 2005, and initially worked in 2 rural districts. As I mentioned before, Southern Kanza and Gray district. Rwanda Hospital, which some of you may have heard of, is kind of the biggest, sort of most bustling PH site in Rwanda, is in Southern Kayonza. And then Gray Hospital, obviously, is in Gray. This is a picture of the clinic at Rwanda Hospital. And I wanted to show you all a quick video to sort of give you a sense of what cancer care was like around the time Partners in Health started working in Rwanda. And this is about a patient who was treated at Rwanda Hospital in 2006.
Byabanyita tuyishime Francine, mfite imyaka 15. Ndi kunjye natangiye ndwara, nafashwe mfite akantu k'agasemukano. Nari mfite uruntu rugera hano. Yagiye mu bitaro bya mu bavuzi ba Kinyarwanda, noneho birananirana baranzana. Ku buryo wabonaga ndi umuntu ndembye nenda gupfa. gutekereza ko ntazakira icyo gihe ariko bwa mbere bampaye imiti. Hari igihe numvaga nshaka kwiheba ariko indwara nkayirwanya kugira ngo ngarure imbaraga kugira ngo ngire. Barayimaye ubwo bakajya bamfukura uko bamfukuye hakomokana nk'urunyama, noneho hakajyayo kaba gatoya mfata chimiotherapi ubundi mba ndakize. Ubundi njya kwigana n'abandi bana uko bisanzwe. Njyewe nkunda kwiga Icyongereza, nkazatsinda nkaba umuganga. Ndabifuriza ko bazarwara bagakira nk'ubundi nk'uko nanjye bampaye iyo miti nkakira.
And so I show Francine's video for a couple of reasons. First, her story is very, very exceptional, especially at that time in Rwanda. Most patients would not have gotten even a diagnosis, let alone treatment and a cure. There was very little cancer care available at that time. Also, she presented with pretty impressive disease. I think probably in the US we don't see a whole lot of people who get this far before they reach presentation and get some kind of care. And I think her story illustrates some of the challenges. Another thing that she mentioned was that she first went to a traditional healer and then eventually made it to Rwanda Hospital. Many of the patients that we've talked to talk about going to traditional healer, a number of health centers, maybe a hospital, before they ever can get a biopsy and a diagnosis and eventually be treated. I would also like to, talk about her story because she was a very early success. It was amazing that she was treated and cured. And Partners in Health, since opening their doors in Haiti in the mid-1980s, in Rwanda, in Malawi, Lesotho, all the places they were, have seen patients with cancer come to their hospitals. Because even if you specialize in HIV or TB, patients who've been there sick will come, and a lot of patients obviously have cancer in these settings. And there have been these sort of intermittent successes, but the hospitals were not well equipped to provide good cancer care, good multidisciplinary cancer care. And so there was really a need to set up a formalized program, and that's what we're going to tell you about tonight. Dr. Brown will talk a little bit about what goes into making a good multidisciplinary cancer program. So the center actually came to be at Butaro Hospital. Partners in Health started working with the Ministry of Health in Burera District in sort of 2009, 2010, and then built this hospital, which was opened in 2011, which is a gorgeous facility. I'm actually going to show you another really quick video that was made by Time Magazine. Everybody likes videos, right? But they have some great footage of the hospital.
He has bad respiratory distress.
Talk a little bit about the
At a
district.
hospital in northern Rwanda, one of Dr. Alexandra Vinograd's newborn patients struggles to breathe. She needs an x-ray to pin down why.
So this baby's going to x-ray right now?
The very fact that there's an x-ray machine in this poverty-stricken area is remarkable. To the local people, it's even more remarkable that this hospital was built for them at all.
There was one doctor in this entire area. It was in a district of 400,000 people, and there was no hospital here.
Amid these farm fields, this new public hospital opened January 2011. And it's been turning heads and inspiring new ideas, even outside Rwanda, as a model for new ways to bring healthcare to the poor.
When the hospital was first built, the local population did think it was a hotel. They couldn't believe that this was actually a hospital for patients. It's so beautiful that in addition to the medicines, I think people feel taken care of as well.
The Butaro Hospital's unique design and approach was shaped by Paul Farmer.
Okay. And that's about a 6-minute video. If y'all would like to see the rest of it, you're welcome to Google it. But it talks about a lot of the challenges that physicians end up facing more generally taking care of patients in Butaro Hospital. So this hospital was opening about the time that the Ministry of Health, Partners in Health, Dana-Farber, were all thinking about making a formalized cancer center. And this hospital was well equipped to actually have an oncology ward to develop a pathology lab. And so it was decided to develop the cancer center there. And talked a little bit about how they sort of started this off. There was a very close collaboration between the Ministry of Health, Partners in Health, Dana-Farber, also Brigham and Women's really helped a lot with the pathology lab, Boston Children's Hospital. There was a large training program in April 2012, which where you were at that point. Yeah. There's been another one since then. There are weekly calls set up between the Rwanda and Boston teams to discuss patients. They have a nursing training program, which Laura's going to talk more about, where they had a Dana-Farber nurse on the ground for a year. It's actually being extended. And then a pathology lab was operationalized. And this is a critical component to providing cancer care. And that has sort of been slowly built up with increased capacity so that they can actually do biopsies, process tissues on site without having to send things back to the US. And then in July 2012, it was formally declared a cancer center. A number of cancer protocols were designed, and these were all sent to the Ministry of Health. They were approved as national cancer protocols. And this helped really define what cancers would be safely treated in this setting and what regimens would be used. And Marshall will talk a little bit more about sort of the thought that goes into that. And with that, I will actually turn it over to Marshall.
So it's a great pleasure to be here and to see this wonderful crowd who's interested in medicine in a different setting. So I was lucky enough to spend some time in Rwanda this winter. And what I'd like to focus on today are two things. Firstly, the burden of cancer in Africa, which I think is going to become a growing problem during your time. And then secondly, I'm going to concentrate on what it takes to develop sort of a cancer program. I know all of you can just imagine the advanced cases of cancer you see, so I'm not going to concentrate on that, but sort of on the nitty-gritty of what it really takes to get something that works. So I think that it's important to understand that cancer is really an emerging public health problem in Africa. So in the 2008 database from the International Agency of Research on Cancer, there were 15,000 new cases and 500,000 deaths. And it's estimated that this is undetected by at least 50%, because one of the things that we are noticing is that the cancers we're seeing in Butaro are obvious cancers. So children get a lump in their neck and their parents bring them in, or they get a big lump on their leg and they have a sarcoma, their parents bring them in. But the more internal cancers, the lung, the pancreas, the gastric, the hepatocellular, which is probably making up more than what we even see, is just not detected. So it's really, they're very, very much underestimated, and so it is clearly a huge public health problem. These numbers are expected to double by 2018. So you can imagine the resources and so forth that this is going to cause. So the causes of the increased cancer burden is number one, the aging population, number two, a growth in population. It's estimated that the population of Africa is going to increase 50% between 2010 and 2030. And there's an increase in the number of risk factors that, we don't know what causes cancer. That's a Nobel Prize waiting to happen, but we know some things. But certainly there are certain risk factors that we understand predispose patients to get cancer, and these risk factors that are associated with economic transition may be increasing. So among these are smoking, obesity, physical inactivity, and reproductive behavior. So in some ways very, very similar to what we see as problems in the United States to try to direct our prevention towards. At the moment, so just to talk a little bit about these risk factors, smoking, at the moment the prevalence of adult smoking in Africa is low. I didn't see one case of lung cancer in Butaro, and I didn't see anyone smoking. Now I understand it is illegal to smoke outside the home, so I asked some of the doctors and nurses whether people smoke in the home, and it's very rare. They don't have a disposable income. It's, there's no advertising, no billboards. So anyway, at the moment, the prevalence of adult smoking is quite low. But there's a lot of concern that as disposable income increases and as there's an adoption of Western lifestyle, which are driven by images and newspapers and films that make it look romantic, just as it's always been, that this may in fact become more of a problem. So this is certainly on the radar of the public health people. Also, there's going to be an increased prevalence of reproductive changes. So early menarche is, often is more often seen in Western countries and more developed countries than in less developed countries, and that may become more of an issue as their societies get a little bit more westernized. Delayed childbearing, early childbearing is protective against breast cancer and ovarian cancer, and so that may also become an issue. And lower fertility rates as things become a little bit more, I should say, westernized. And I'm thinking of that in a negative sense here. Also, diet and activity are changing, so dietary changes that lean more towards high animal and hydrogenated fat intake, and activity patterns changing so that there is a reduced energy expenditure as people come to the cities and away from the farms. The patients that we saw and the people that we saw in Rwanda were in general in superb shape. I mean, they don't have the best diet. It's very starch-based, so it's very natural. There's no additives. But, they walk everywhere. There's hardly any cars. And these women, have a 25-pound bag of potatoes on their head and a 30-pound baby on their back, and they're walking up these hills with me with my pared-down pack, where I won't even bring my glasses so I don't have to carry them uphill. I'm walking next to these women. So they are in good shape. So that's going to become more of a problem. So this public health issue is only going to increase. At the moment, cancer is a very low public health priority, in part because it's unrecognized. There are other public health problems that take precedence, like tuberculosis, HIV, and malaria. And one of the reasons I think Rwanda has been able to think about cancer is they're sort of getting a handle on these other public health issues. And as other countries do that, then cancer is going to become more of an obvious problem. Also, there's just the general lack of awareness, because as I said, there's probably underreporting of 50% of the cancers in Africa. They're not aware of the magnitude of the current burden or the future burden and the economic impact it can have, not only the personal impact, but the economic impact. So this is just, this is a map that shows the most common cancers in males and in females. So as you can see, in females, breast and cervical outweigh everything else, and that's sort of good, because there's things that we can possibly do about that with vaccinations against HIV and with early detection for breast, and to make these things potentially more curable. For men, the distribution of cancers is somewhat related to the part of the country they're in. So in the northern Africa, where there's more smoking, you see more lung cancer, and certain countries where you have more HIV that's not so easily controlled, they're seeing more Kaposi's. And then hepatocellular carcinoma is a major problem everywhere because of hepatitis B infections. So the opportunities are endless for all of you sitting here. So in terms of cancer opportunities, the main things that, main categories are in prevention, early detection, trying to cure people, and palliative care. So very similar to what we do here. So prevention, clearly being able to give hepatitis vaccines, HPV vaccines, and controlling HIV can make a huge dent in the cancers that are caused by infections. And then lifestyle changes affect patients in developing breast, colon, endometrial, kidney, esophageal, pancreatic, almost everything. So again, education about lifestyle changes is another area. And then, of course, tobacco use. So, the public health departments in these countries, of course, are thinking about undertaking all of this, but that's a huge, huge area, and prevention is better than anything we can ever do as chemotherapists or oncologists. So early detection is the next opportunity. I must have seen, I don't know how many breast cancer patients when I was there, maybe 100, a little over, and I saw one patient who was 20 years old who had a 4.5 centimeter mass because she was developmentally delayed and her mother showered her and found this mass on her breast. But I didn't see anyone else that had a mass less than 5 centimeters, and everybody was 8, 9, 10, 18, 20 centimeter masses. So clearly early detection could make a huge difference in curing these patients. So that's another educational opportunity and prevention opportunity. And then, of course, curative treatment, and that's what we have been trying to set up in Rwanda, curative treatment through multidisciplinary treatment of radiation, surgery, and chemo, and I'll talk about that in a little bit. And then palliative care. So palliative care is another huge area because many of these patients, perhaps most of these cancer patients at the moment, can't be cured and even can't be treated because of low resources. So as a result, you have patients who are in pain and need palliative care. And I read one statistic as I was looking through some statistics for this talk, where if you, I think they said they were using, if you add up the amount of morphine patients need in just one African country, it's like 6,918 kilograms, and right now they're only getting about 600 kilograms of morphine. So you can see that there's only this huge deficit in palliative care and our ability to deliver it. So that's another huge area. So this is a bit of a dry slide, but I want to show you how cancer care is really a continuum, which starts with education, because then you can have prevention and not need us at all. And then education with early screening gives us early detection, and again, higher rates of cure. And you know all this. And then if you have early detection, you need diagnostics and ultimately treatment. And then once patients are treated, they either are survivors or you need palliative care. So this is sort of the whole spectrum you need to keep in mind when you're thinking about setting up a program. So the partnerships, now these next slides are borrowed from Larry Shulman, who is the director of the Global Medicine Oncology at Dana-Farber, and who's the person who was instrumental in setting up this whole program. It's his work, and so I'm using his slides because they're very well thought out, and they reflect what's happened in Rwanda. So in order, and I'm explaining how you sort of set up one of these centers because it's applicable to all the types of diseases you might be interested in, and because you all are probably going to be setting up these things and being leadership positions for this type of thing in the next decade. So it's not, so it's something just to sort of keep in mind. So partnerships are very important because you can't do this in isolation. And the partnership for Rwanda, just to give you an idea, includes the Dana-Farber, the Brigham, Children's, Mass General, Harvard Medical School, and the School of Public Health. All wonderful and very high-power institutions, and you need that kind of work. And then, of course, Partners in Health, which contributes a healthcare structure and knowledge about how to do healthcare in a low-resource setting. The Ministry of Health and the governments that know how that health can fit into their culture and how best to deliver it within their systems. Generous donors that can help give the startup money to get some of these things off the ground, and then industry, which is extraordinarily helpful in providing some chemotherapy devices, and in the case of GSK, some training. So I think these are all important aspects of being able to have a successful cancer center. So Dr. Shulman has sort of laid out these principles of how you set up sort of a cancer center in a this is low middle income settings. It's best to set it up within the existing infrastructure that exists and not try to reinvent a whole wheel, because you need support, especially for cancer, from every other aspect of medicine. The development of essential services is extraordinarily important. So pathology, if you can't treat, you can't treat without a histologic diagnosis, period. So if you can't diagnose what they have, then you don't ever get onto first base. And the Brigham has been very helpful in being involved with pathology, and David set up a telepathology center while we were there so that we were able to do a biopsy on a Wednesday, send the slides to them by telepathology on Thursday, and Thursday afternoon see that this kid on Wednesday had a Burkitt. So it's really extraordinary, and that's what you need, these types of services. And you need to have a multidisciplinary approach. There's no sense giving chemo without radiation and surgery, and vice versa. So that's extraordinarily important to keep in mind. Just to show you the range of the problem, though, this is the slide that shows the number of people per radiation therapy machine in Africa. So, there are patients, there's one over 30 million, one machine to 30 million people in Ethiopia and the Congo and Uganda. And you can see Rwanda doesn't have a radiation therapy machine. So we're sending our patients to Uganda by bus, which is extraordinarily time-consuming, expensive, and difficult for the patients to leave their home. So this is a huge issue in giving multidisciplinary curative care. The next thing you need to do is you need to develop a very stable supply chain of drugs, or vaccines, or whatever it is you're using in your aspect of medicine. If you, in oncology, if you stock out of a critical drug and you can only give part of a regimen, then there's no sense even giving the regimen in part because the patient's ability to be cured is very compromised. So we've had a couple stockouts with dacarbazine in patients with Hodgkin's disease, and it's always very distressing to us because you then end up delaying them unnecessarily, and if you don't go by the data and the protocols that have been proven to cure, then there's, it really is in some part, a bit of a wasted effort. So the next thing is very important. So this is what we've seen in Rwanda, and you have the cancer services are administered by physicians, nurses, and other healthcare personnel without on-site oncologists. So in Rwanda, there's an amazingly talented pediatrician from Children's who was there doing general pediatrics for a couple of years and agreed last July to work in the oncology floor. And there was a Brigham internist who wants to be a cardiologist who has learned oncology to do this. And they have been doing the oncology care, very sophisticated oncology care, with the backup of us specialists via email, via the weekly telephone conferences. But there just aren't going to be enough oncologists, trained oncologists, to approach being able to treat, most of the world's patients, as Larry says. So I think this is a very, very important model, and it's been very successful so far. And successful, I mean, there haven't been sort of, unnecessary toxicity or things haven't happened that you wouldn't expect to happen if you had a trained oncologist doing it. So this expansion, one of the Partners in Health's models is to provide supportive services to all their medical patients, and that doesn't just include medication. It includes social support, clean water, food stability, and so forth. And this is particularly important in cancer, since you're sending patients home and you need to be sure that they have the basics to be able to support their family member at home. The next principle that Larry discusses is developing a prioritization document. Now, this is extraordinarily important. This directs resources to where they can make the most difference. And the reason this is important is because we have very limited resources, so you have to use them wisely. And it's very difficult to make decisions when you're sitting there looking at some child with a big sarcoma that you know is not curable and you shouldn't give them chemo, but you really want to. You can't. It's hard to send them away. So it's much better to be made with careful thought, by the data, with a lot of careful consideration beforehand, so that it's easier to apply it when you get there. I'm a seasoned oncologist, and I fell prey to this many times when we didn't have a protocol in a certain disease. A value to benefit ratio. So if you have a 4-year-old with Burkitt's lymphoma that has a high cure rate and we have low-cost drugs, then that's a really good thing to be able to treat. And a 23-year-old man who's young with CML that you can't cure, but you can get him Gleevec, and he has a pretty excellent quality of life for many years, then that's a moderately high value. But an older person with advanced gastric cancer who we couldn't even treat here and cure is not probably someone that we want to at the moment put resources into, but palliative care resources are extraordinarily important. Yes?
So are these decisions for drug allocation made at the government level or the hospital level? What?
That's a good question. At the moment, we have, the FARBR has written protocols for the most common tumors. So for breast cancer, colon cancer, leukemia, in conjunction with Children's Hospital. And so if a patient presents with X, they do Y. It's very well spelled out. And so it's sort of written by experts here, and then it's brought to the Ministry of Health, and it's put through a national IRB so that the Rwandans have access to comment on it and change it. And then we're trying to do it nationally. So not only are we doing this in Butaro, but the docs in Kigali, the Rwandan docs in Kigali that have seen cancer patients are, this is a national protocol, so this is the approved way of treating it. So it's being made in a group with input from the government, but not restricted to the government.
If you have limited resources, who's deciding, does a certain hospital get a certain amount of?
Yeah, that's a good question. At the present time for Butaro, the Dana-Farber is involved in Butaro, and Partners in Health is involved in both Butaro and the hospital in the south in Kwabu. And so the resources are going to both those places through the Dana-Farber. And the hope would be that eventually that will expand as the Rwandan government gets able to take over some of the costs and so forth. But at the present time, they're primarily in those two centers. And that's a very good question. It's very hard. And things aren't written in stone, so even though the protocol says, don't treat this kid, sometimes we're treating this kid, right, because it's really hard. But what should happen, to be very fair and honest about it, is that you do make these decisions beforehand based on data, who's curable, who's not, and then think of the best way to implement that and the best way to have very supportive palliative care for those that don't have curative disease. So here are those cancers where we think we can make an impact, and there are certainly those that are where we can reduce the risk in tobacco-related cancers, HPV-related cancers, and hepatitis and alcohol-related cancer, hepatocellular carcinoma. There are others that have early detection with breast cancer and cervical cancer, where they make a huge impact. And then there are diseases that are curable with chemotherapy that's not too expensive, and that includes a lot of lymphomas, Hodgkin's, testicular cancer, sarcoma, and ALL. So there's quite a long list of diseases we can cure there with affordable chemotherapy. And then diseases that we can palliate with systemic therapy, although not cure, are CML and CAP disease. So this is a list that sort of generally tells us that tells you what we're able to think about doing with various diseases. So the last principle is that you do need to develop specific disease-based protocols, and that gets to your question. And what we're doing here is that we try to have a protocol on all the diseases that we see over there. And one of the things that we're doing is we're sort of changing them as we learn that certain situations exist. But the protocols are all data-driven, and they're we try to make them realistic to what you can do on the ground. I mean, some of the sarcomas you can't do high-dose methotrexate, you don't have ifosfamide, so you really can't cure certain sarcomas. But there are other protocols where we can treat sarcoma, but maybe not quite as high risk, where you can cure them because we can get adriamycin and platinum. So it's a constantly changing area, where we just had a meeting a few weeks ago where we sort of put together everything we've learned this winter from some of us being there, and we're redoing the GI protocols, and we're having new sarcoma protocols, and we're redoing some of the breast protocols to have them be applicable to Rwanda and yet give the highest chance of cure while using the resources wisely. I mean, it's not good for the patient either if you treat them and they can't be cured, because it's a huge price that the patients pay to come there to get their therapy. It means someone's out of work, someone can't take care of the family. It's extraordinary, and they are coming from other parts of the country. Butaro is, way far in the north, so they're coming from all over the country. So it doesn't serve the patient well either. So that's what we're trying to just make it, so that we treat the curable patients. Yeah.
And when you guys are revising these protocols, are you revising them based on trials that had happened in from papers 20, 30 years ago, or are you collecting data from the field and then?
That's an excellent question. Right now we're writing them based on protocols that were done in the States or in Europe, and there's some, the ALL protocol is a protocol that was done by a guy named Steve Hunger, who's at St. Jude, I believe. And
he's in Colorado.
He's in Colorado now, yeah. And so he has written, he has looked at what ALL protocols are accessible to different resource settings and what the cure rates are. And so that's sort of a very special situation. But most of the time the data comes from data in the US using drugs that we have in the US. So it's a little bit hard sometimes to extrapolate. But the data collection, which I didn't put on here because in the interest of time, data collection is extraordinarily important. And that's where there'd be lots of projects for anybody that is interested, because everything needs to be data-driven, and we don't know the impact of what we're doing yet. We don't have any outcome data, or much outcome data yet. So that's going to be very important, and that will then have us change the protocols. Yes?
I was curious to know, you had mentioned that there were 2 residents or fellows who had received oncology training, and then just with this talk on protocols of what capacity building or trainings exist for the Rwandan physicians and healthcare workers as part of this collaboration with Butara Hospital?
Yeah, so there was national training for both the doctors and the nurses that Larry Shulman, Dr. Shulman, and Laurie were involved with. And then on the ground, we try to do, we have a Rwandan doc who comes to clinic, comes to rounds, and we try to have someone that comes every day so that they learn sort of on the job. Plus I gave some CMEs when I was there to them. The expat docs, the Brigham and the Children's, haven't had any official oncology training except what they got in their general residency. And that's why the protocols are so important, because they can follow the protocol, but they couldn't write the protocol because they don't have the training involved. But experts back here have the training. And then they can say, it doesn't work, this protocol doesn't work because X, Y, Z. And that was one of the reasons that I went as a trained oncologist, was to just sort of see what works and what doesn't, what would we need to change, and what is working very well. So it's a very it's a very dynamic system of changing these protocols, but they're very important because they should be data driven. Be sure you're giving chemotherapy when you can cure somebody for many reasons, and also because you have non-oncologists doing oncology care. So having protocols by people who know what the oncology care is makes a big difference.
Thank you.
And when I got there, the Brigham resident, she would say, here I'd be I'd see a patient in clinic, and she'd say, well, this patient has this, so we should do this. I mean, she knew the protocol, she knew exactly what to do. She didn't need to even ask me about many things, so it really seems to work quite well. Okay, and then developing a research agenda in conjunction with the government of Rwanda and the docs in Rwanda. There are partners in health personnel that are there teaching Rwandan docs how to write a paper, how to do statistics, and so for us to develop a research agenda, and they participate in this research agenda to try to determine what do we need to know. We need to know everything, but what should we do first is very important. And so that is something that is wide open because it really hasn't been started yet. And then training, as you brought up, there's a lot of people there that are very interested. It's critical that they're well trained, and Laurie's going to address that with the nurses, so I won't say much more about it, but the training needs to be constant. And sustainability, so the goal is that, we can all get hit by a Mack truck and the place just continues to run. And so I think that is the ultimate goal, is that we do things that are realistic and high quality, and we teach people how to do it and be able to do it without us there. So the next steps are training Rwandan docs and nurses in greater oncology expertise, and that's continually ongoing. More training in palliative care, which is a huge issue. A more reliable drug supply. We still run out of things, even with the pharma being so generous as to donate things, we still run out of things. Looking at how we can implement things we learned from epidemiology and treatment outcomes to go back to the protocols of how we should be treating patients. And the more we do pathology, the better. So that is also an increasing need. And we are opening an ambulatory oncology center, which I won't go into great detail, but the patients can get their chemo in an ambulatory setting. Right now they get it in an inpatient setting. And then radiation therapy, we're looking into that, but there are issues in terms of energy supply, expertise to fix it when it goes down, and so forth. So that's ongoing. They're looking very seriously into it, so we can have a real multidisciplinary team, because we have a good surgeon now who's from Uganda, and so we have surgery, we have chemotherapy, we have radiation. So it's a real mix. So can we help make a difference? Definitely. And I think we can really challenge this notion that you can't treat cancer well in poor countries. I think we definitely can do that. So I open it up to questions and comments. Okay, I'll have Laurie talk to you about the nitty-gritty, how to do it every day.
So I'm going to talk about administering chemotherapy in a resource-poor country. So I'm going to talk a little bit about the nursing fellowship that we developed, and the latter part of my talk I'm going to talk about what it's the day in the life of the oncology ward, what it feels like. So I think many of you know Paul Farmer or about Paul Farmer, and I think a lot of stuff that he has done in Partners in Health is by serendipity. And the way that our nursing fellowship program started was serendipity. One of our pediatricians, Leslie Lehman, was in, I think, Ethiopia or Egypt, and was going to stop by Rwanda on her way home. And she happened to have our nursing director with her. And she said to Kathy, do you want to go to Rwanda? And Kathy's like, sure, I'll go to Rwanda with you. So they go to Rwanda 2 years ago, this summer, I think it was, and Larry Shulman is there. They didn't know he was going to be there, and Paul Farmer is there. So they all make a trip to Butara, which is about a 3-hour drive from Kigali on half tarmac, half dirt, bumpy roads in the back of a Land Rover. And Kathy says to Paul, you know, you've done great things for doctors, but you know, your doctors are practicing up here in all these resource poor countries, and the nurses are down here, and how come you're not doing anything about nursing? And you need to train nurses too. So Kathy and Leslie and Larry came back and started talking, and lo and behold, Dana-Farber decided that, along with Partners in Health, that we were going to help train nurses in oncology because we had the expertise, and they were giving chemotherapy, and everybody knows it's the nurses that do all the work in oncology. So we started this fellowship program. And as Marcia mentioned, it really is a collaboration. We are there at the invitation of the Rwandan government and with Partners in Health, and we couldn't do it without that support. The way that we have supported this financially is we do have a center now at Dana-Farber, and we have a small operating budget. We also have some philanthropic funds, donations that people have made, and that's really what has allowed Dana-Farber to take a nurse offline and send a nurse to Rwanda for a year. And the way that we structured it was we just completed 1 year there, and so we had 4 different nurses go for 3 months each. And quite frankly, it was really a year of learning, I would say. I think we accomplished a lot of things, but I can say for myself, I feel like I learned as much as I taught, and I think that as we continue with this program, that we will get better at it. You know, we work in an ivory tower right down the street where we have all the resources we want and need, and it's a different world over there. So we have just started our 2nd year. Ann Alprin, who was the first nurse to go over, just left this past weekend and is over there again for a 3-month period. We also, over this past year, have started to work with a PIH site in Haiti that is also doing oncology care, and we'll be starting a nursing fellowship there in August, and we have 6 months of nurses from here lined up to go there. So when we really hoped that we would do is increase the nurses' knowledge of what are the cancers in Rwanda. You know, I think they thought they knew what they were, but I think it wasn't until they opened the cancer center that they really began to see what was out there. We really wanted to teach nurses about how to handle chemotherapy safely and how to administer it safely. It's a little bit more complicated than, you know, a potassium replacement or PO medications. We wanted to teach people about side effects of chemotherapy and how to manage those side effects, and then also some palliative care principles, since many of the cancers present so late. We did this in a number of ways. We had prepared talks that we would sit down with the staff and go over. We worked side by side with them, you know, on the units every day. It really tried to help mentor them. We developed standard operating procedures of like, how do you mix chemotherapy? How do you administer chemotherapy? How do you manage IV lines? And I think that was something that the first nurse who went over, one of her first calls back home was, oh my God, there are a lot of wounds here. I need some material on wound care. You know, whether they were bed sores or advanced cancer that had, you know, turned into fungating wounds. So we did some work like that. We also developed competency checklists so that as we were teaching them, we could assess that they were competent after a while. And you know, what we really are trying to do, and it might take a little longer than we initially thought, is train the trainer so that we don't have to be there forever, that we can teach them and then they can teach others. And Butaro is really targeted to be a teaching center for oncology in the whole country. And by next January, we're hoping that we will be able to host nurses from other hospitals who might come and spend 3 months there and learn how to take care of cancer patients. So that's what we're really working toward. I think the things that we accomplished in the first year is we designated a space to mix chemotherapy that was off the ward. Chemotherapy in itself is carcinogenic, and in this country we have all kinds of pharmacy regulations about having a clean room and a hood and exhaust. None of that exists over there, but we at least got it mixed, not on the unit, away from the patients. We taught staff how to wear the personal protective equipment, the goggles, the masks, the gloves, the gowns, so that they didn't get constant exposure to the chemotherapy. We trained them how to mix it, how to administer it, and there are some chemotherapies that are really tricky to administer because if they're not given directly into the vein during the entire infusion, it can cause really a burn in the subcutaneous tissue that requires plastic surgery. One of the things that I definitely noticed when I was over there is that the nurses' knowledge of chemotherapy and side effects increased tremendously. And you'll see when I talk a little bit later about translation. So the 2 expat docs that are over there don't speak the native language. So anytime they go around, it has to be translated by a nurse. And one of the doctors was telling me that after a while, you know, she picks up a few of the words. The nurse gets ahead of what the doctor's saying by explaining what some of the side effects are and what we'll do to help the side effects. So I think the translation actually helps the nurses learn about chemotherapy and the treatment. We also were able to develop some SOPs. We put some systems in place for nurses to identify what are the tasks that they need to get done after rounds. There were many days, and probably still are, that things were identified, but the next day you'd go on rounds again and those things didn't get done as was intended. We also did some outpatient clinic systems improvements, like organizing their charts and having a scheduling system. So on any given day, they never knew who was going to come to clinic, so they never knew what charts to pull, and whoever showed up is who they took care of. I think what we will work on in the future with them is really, so we have an SOP, it's a piece of paper, and it's there for a reason, but you need to adhere to it. So reinforcing all of the components of that. I think that there's lots of opportunity for discharge teaching that we haven't quite gotten to. David also talked to you about how the healthcare system is set up, and there are these health centers throughout all of Rwanda, and when a patient is discharged, we tell them, if you get sick or don't feel well, go to your health center. And health centers are located throughout the whole country, and they are supposed to be located at the most an hour walk from anybody's home. So they're all over the place. But what we found is that the health center nurses didn't really know how to respond to the things that our patients were coming there with. So there is a big need for education among the health center nurses around oncology. There's also continued education that we need to do around nursing interventions for either side effects of chemotherapy or symptoms of cancer. There's also, and it took me a while to understand this, there's something that I think we can teach them about attention to detail and when it matters. So, in our country, we know that doses of drugs are really important and we pay attention to that. In Rwanda, they don't really, their life isn't precision, they don't think about precision. And for a lot of things it doesn't matter, but for some things it does matter, like doses of chemotherapy really should be as exact as you can. So I think we need to teach them when it doesn't matter and when it really does matter, and around a lot of things around chemotherapy it does matter. And then just general organizational efficiency. With limited resources, we could help them be more organized so that they would get more out of their limited resources. So just to talk a little bit about the baseline training, about a year ago, we did the first national baseline cancer training, and it was nurses and doctors together. I think we had about 61 participants attend the training, and it was a 7-day long lecture series, and we did home visits. Since that, and that was mostly done by doctors, American doctors, and nurses went over and did the training. There was another nursing training in November, and a few Rwandan nurses who had now been taking care of cancer patients did some of the training. And then the last week in March, I happened to just be finishing my time there, and we did the third training. And about 80% of the lectures were given by Rwandan nurses, which was just wonderful to see such a quick transition of them taking the material, using their own knowledge and expertise to train their colleagues. And we're continuing to refine the material as we get feedback from the participants, and the training will continue to go on. There was also a second training for physicians, although for the second training they split nurses and doctors, and I'm not really sure why. But this was a picture of our graduating class from the first training. At our first training, which we got a translator's booth and earphones so that if the talk was given in French, it could be translated to English for the people who didn't know French, or if it was given in English, it could be how they were able to take all that material and really get it out to people in the language that they understood. English is the official language in Rwanda now, but up until a couple of years ago, French was the official language. Most of the population speak Kinyarwanda. Most of our patients can everybody hear me okay? Most of our patients didn't speak English or French, so the nurses translated in Kinyarwanda. These are just the topics that we covered in the nursing curriculum, pretty much what you would expect. So now I'm going to, and I apologize for reading, but there's a lot of details here. We're just going to walk through what a typical day was in Butaro Hospital. So my name is Gilbert. I'm 29 years old and the charge nurse on the oncology ward at Butaro Hospital in the northern part of Rwanda. As I approach the ward this morning, I see 3 of the children, Fabrice, Emmanuel, and Kevin, all with Wilms tumor and on the post-operative portion of their chemotherapy. They are outside kicking a Fanta soda cap across the cement floor of the veranda just outside the ward. They have become good friends during the chemotherapy, many, many trips to the hospital. No one would ever think that they had cancer or were currently receiving chemotherapy. They are active, well-appearing, and full of energy. I walk onto the ward. There's activity everywhere. Some patient and family members are in beds. Some patients are walking around. Some kids are running around the unit. The kitchen staff is delivering breakfast. I see Vanessa tied to Mama Davine's back. I wonder where Vanessa's mother is. But it's not unusual to see parents care for other children when their own parents have to run to the village or have to go back home for some reason. This is breakfast. The MDs at the nurses' station preparing to write chemotherapy orders for the day. They look at each corner of the unit to see who arrived the evening before to then determine who needed orders that day. Many of the patients are known by sight. Some look familiar, but the name isn't coming. Then there's a discussion among who's who between the nurses and the doctors. The nurse speaks loudly across the unit in Kinyarwanda, asking the patient for their name. The paper charts that are stored in the back room are gathered for the patients that are here today in preparation for rounds. Angelique, a young woman with a large facial tumor in the bed next to the nurse's station, is moaning in pain. She occasionally leans over the side of the bed to spit up and retch in her bedpan. She's here alone. Most of the other patients have a garde-malade, and that's a personal caregiver who does a lot of the care of the patient on a daily basis. Takes them to the bathroom, bathes them, feeds them, looks out for them, makes their bed. The doctors write chemotherapy orders for the day. We have just started to use the computer to write orders, so orders begin spitting out of the printer. We also have a new drug report for the orders that list all the chemotherapy and pre-medications that we need for the day. Before getting the new computer system, the nurses had to handwrite the list every day of all the medications that we needed prior to giving it to the pharmacy. That usually took about 1 hour every day. The doctors are ready to round. We have a stack of charts on the rounding card. Dr. Molly pushes the cart to the first section of the ward. I see Theogene, one of the nurses, walking out of the unit. He's going to pick up results from all the patients who had blood drawn last night in preparation for chemotherapy today. Vestine is sitting at the nurses' station in front of a crowd of patients in their garde-malades. These are the patients who will be discharged today. Vestine is going through every chart of every patient who's being discharged to write up their charge ticket. The patients then take the ticket, go to the social workers, pay their bill, come back to the unit, have their IV taken out, and then they can go home. Molly approaches the first patient, and I accompany her. The patients and family members see us starting rounds. Some of the patients make their way back to their beds. Molly asks me how the first patient is doing. I translate the questions into Kenya Rwanda. This is Angelique, the woman with the facial tumor. She had chemotherapy 2 weeks ago, but came back last evening because of pain, even though she isn't due for chemo and for another week. Morphine seems to work well for her, but is only available at the hospital in IV form. We have no oral narcotics to send patients home with. She states there's a lot of pressure in her eye. Molly asks me to give her some morphine, and I give her 5 milligrams IV push. She seems to be more comfortable after the injection. We're trying to decide to see if she could go to Uganda for radiation with the next group. Molly wants to examine the patient, but we don't have gloves on the rounding card. So I take some gloves from the IV card. There are only a few left in the box. I translate back and forth. Once we were done, Molly writes a note in the chart. The only nursing issue for the patient today is pain control. We move to the next patient who has breast cancer. We begin the translation. Translating conversation between doctors and patients has allowed the nurses on the ward to learn more about cancer care, especially when the doctor meets a new patient, tells them about their cancer and their chemotherapy and what to expect. Tassiane is an 80-year-old woman with locally advanced breast cancer and will be getting her 4th cycle of chemotherapy today, doxorubicin and cyclophosphamide. Her tumor has decreased greatly, and she hasn't had any side effects. No fevers, no nausea, no vomiting, no diarrhea or constipation. We look for her blood counts from yesterday. Theogene is not back yet. I call him on his cell phone. He's on his way back. A commotion starts over by the door in front of the nurses' station. The parents of 3 of the pediatric kids and 4 of our adult patients come through the door with one of the social workers. All 7 patients are being discharged, and the social worker needs to confirm with the nurses that these patients qualify for bus passes to travel back home. The conversation is loud. I walk over to figure out what's going on. Molly gives me a look because now rounds is interrupted since she can't continue without someone to translate. The social workers always seem reluctant to give out the bus passes to the oncology patients. The way healthcare in Rwanda works is it's managed at the district level. And you can see here the districts in Rwanda, and the yellow ones are where PIH is, and Burera is where the Butaro Hospital is in the north. So you can imagine patients coming from the southern part of Rwanda, it probably takes them well over a day to travel to Butaro Hospital. Patients are seen usually by community health workers or a nurse at the health clinic as a first step. Then the nurse may refer them to a district hospital if needed. Almost all Rwandan residents get their care within their district where they pay into the health insurance system, mutual. In fact, many patients can walk to their district hospitals. Those who are too sick are transported by stretcher carried by young men in the village. And usually it's in hills, and there are a lot of hills, and we did a lot of huffing and puffing when we were walking back to the village. But they are in pretty good shape there. So some patients do get referred to one of the larger teaching hospitals in Kigali, but most patients stay within their district. Butaro Hospital is a district hospital and has only been a cancer center of excellence for a little under a year. As a referral hospital, we care for patients who come from all over Rwanda. Many of the hospital staff are not used to serving patients from other districts in Rwanda. So we often need to intervene and help educate our social workers about our referral hospital status and advocate for our patients since they have to travel such long distances. We review the patients and the social workers hand out the bus passes. I go back to rounds. We continue to see the patients. The next patient is new to us. She presents with a very large breast tumor. I go and get the privacy screen so we can examine her without all the other patients on the unit observing. She states she's had the tumor for 5 years. Her breast is totally involved. And this is not unusual, and this actually are a lot worse than this, where breast cancers and other cancers were open wounds that people have been living with for long, long periods of time. Her chest x-ray shows a few lung nodules, so she has metastatic disease, PR negative. We explained paclitaxel chemotherapy to her, including side effects and the every 3-week schedule. She asks if the chemotherapy will make it all go away. Molly explains that we can't make the cancer go away completely, but hopefully the chemotherapy will keep it in control for a period of time. The patient agrees. She needs to have a urine pregnancy test to make sure that she's not pregnant now. We also stress the importance of family planning to her while she's receiving chemotherapy. This is really hard for young women in Rwanda, since having children is the pride and joy of Rwandan women and families. Theogene returns to the unit with some supplies for our back room: IV bottles, IV needles, alcohol, and tape, and some of our lab results, but not all of them. Tassienne's counts are back, the patient we saw before, so she's okay and can get chemotherapy. The next 2 patients have Hodgkin's disease, and they'll get ABVD today. From what I understand, these patients could be cured. They're both young. It'll be nice to see them do well, as so many of our patients have died since we opened the oncology ward a year ago. Rounds continue. So there you see David and Marsha hard at work. Rounds continue. We have about 24 patients in total, but there are many others on the unit who have been discharged but are still staying here. So patients who travel a long distance, oftentimes in between their weekly chemotherapy, will opt to stay at the hospital, and they stay on the ward, and they're there, and they sleep in a bed, but we don't round on them. But of course, if something bad happened to them, we would take care of them. So there's usually just a lot of activity on the ward. In addition to the extra beds we already have on the unit, we may have to send some patients to other units that aren't full so that they can sleep here tonight. One of the little girls with Wilms' tumor is crying out in pain. It seems like it's abdominal pain, and she appears constipated. She's getting vincristine as part of her treatment, which can cause constipation. We've given her bisacodyl and soap suds enema, but seen very little improvement. Molly says her tumor could be contributing to the problem. We've decided to send her to Kigali for a CT scan to determine what's going on. That means traveling in one of our ambulances, maybe with a few other patients, and one of our nurses to transfer her there. I asked my colleague Vedast, the cancer nurse coordinator, to help make the arrangements. We complete rounds around 2 o'clock in the afternoon. Other notable patients include a 40-year-old breast cancer patient here for chemotherapy. She had a mastectomy about 6 weeks ago. Her incision is healing nicely. I just remembered we got some donations of breast prosthesis and some bras, so I go and get her one. She tries it on. She's really happy. This is probably the first bra that she's ever owned in her entire life. A 39-year-old, this is Marsha teaching one of our Rwandan doctors. A 39-year-old non-Hodgkin's lymphoma patient who seems to be getting worse. He had one cycle of CHOP chemotherapy a couple of weeks ago. When he came in, one of his lungs was totally gone. He can barely keep his eyes open. His oxygen is on. His breathing is labored. He's very thin and can't eat anything. He opens his eyes when you speak to him, but he can't really respond. His brother is here with him as his guard alive. A woman who finished chemotherapy for breast cancer a couple of months ago came back yesterday with complaints of headache, nausea, vomiting, and jaundice. Molly has ordered liver function tests. This morning she feels warm to touch, no vital signs in her chart. We do vital signs and discover she also has a fever. A 72-year-old man with bladder cancer is getting very intensive chemotherapy. We located his bed at the end of the ward near the bathroom since he has to get up to urinate so frequently. While we ask him questions about how his night was, the neighbor in the next bed answers the questions for him. A lot of patients who sleep next to each other night after night after night get to know each other pretty well. As a matter of get to know each other pretty well and about their medical condition. So there really aren't the HIPAA concerns that we deal with here. Everybody knows everybody's business. It is really nice in many ways because they are such a community of support for each other. Theogen is measuring the height for a new patient who's starting chemotherapy today. Vadas calls me on my cell phone to say that the ambulance can take our wellness patient to Kigali this afternoon. That means I lose a nurse for the rest of the day. We write the transfer note and get the patient and her mom ready to go. I will send the steam to accompany them. Theogen comes back from the pharmacy with our chemotherapy drug order for the day. He announces that they have run out of dacarbazine. That means the 2 Hodgkin's patients can't be treated today. Dr. Molly is upset and sends an email to our medical director and the procurement team about the stock out. We have a procurement team who is working to implement a system to track drug quantity, establish par levels, and a system to keep par levels stocked. It's a work in progress. Sometimes we can get what we need in a few days because it comes from the pharmacy warehouse in Rwanda, the other hospital, which is about 5 hours away. But other times an emergency order needs to be placed with our supplier in India. That usually takes longer, sometimes 2 to 3 weeks. I hope the warehouse has dacarbazine so we can get some tomorrow and don't have to delay treatment too long. It's almost 3 o'clock and I run over to the lunch building to have quick lunch. When I get back to the unit, Vestine has gone to Kigali and Theogen is doing a couple of dressing changes. The public bus has just arrived and 6 of our patients who are due for chemotherapy tomorrow have arrived and come into the ward. They greet and are greeted by some of the many friends they have met here. Everyone's happy to see the patients and their families return. There are lots of hugs and fist bumps. And the other gesture that's really common in Rwanda is this. You walk onto the ward and even the little kids. Yeah. With the eyebrows go up at the same time. Let's see. I think most people who think about cancer in Rwanda think there's nothing can be done to help these patients and that most people with cancer die. I never knew until we opened the unit. I never knew until we opened the unit a year ago what a happy place this can be. And of course there's sadness too when one of our patients died. We've had plenty of those. I need to mix chemotherapy now. We have 16 patients who will get chemotherapy today. I take the order sheets and go to the mixing room. I calculate the amount of chemo needed for each drug that the patient will get so I know how many mLs to draw up. It takes me about 30 minutes to do the calculations. I'm supposed to have another nurse check all the calculations, but we're short-handed today, so I just will begin mixing. I also need to make labels for each bottle and each syringe. We were taught to write the patient's name, date of birth, drug, dose, route, but it's too busy today to do that, so I'll just write the patient's name. I put on the protective glove, gowns, masks, goggles, and start mixing. After only drawing up 2 patients' doxorubicin, I run out of 20 cc syringes. So I take off my protective equipment and I run to the pharmacy to get more. I finish mixing everything for the day at 5:30 p.m. This is much later than usual. Theogene has already pre-medicated all of the moms because she's trained to give chemotherapy. She and I divide up the chemotherapy and start administer it to the patients. One of the patient's IV is no longer in the vein, so I'll have to put a new one in. We finished giving chemotherapy at 8:45 p.m. I still need to sign all the orders indicating that I gave the drugs. I leave them on the desk to be filed tomorrow in the charts. I am grateful that I only live 3 minutes away from the hospital. I am tired after a 14-hour day. Walking home, I realize we probably have patients with Hodgkin's disease coming in tomorrow for treatment the next day, and we have no dacarbazine. We didn't think to call them to tell them not to come in. I need to remember to call them tomorrow if we can't get the drugs from the Rwanda warehouse. That's a typical day, would you say? The other person I want to introduce is Barbara Burchak, one of the nurses from Dana-Farber who was in Rwanda, our second nurse. And some of these were Barbara's pictures, actually, she was in one.
Yeah, so thank you all very much. If you have any questions or thoughts, we can open it up at this point.
I have a question about the nurses and the doctors program. So are the nurses and the doctors in training, are they dedicated to oncology only, and sort of where are they recruited from?
So in Butaro, there is a unit. It is staffed. I think when I was there, we had 8 nurses there. We actually got approval for 3 additional nurses, and they only work in the oncology unit. And they were actually recruited from the medicine ward. Barbara, you were there actually when the unit opened. They worked on other wards and were somewhat hand-picked for the oncology ward. The physicians, I think, were also designated, but at least up until this point, the physicians also cover other aspects of the hospital. So they did the on-call rotation. So if they were on call or had weekend, then they had days off during the week. So there were some gaps among the Rwandan doctors in the oncology unit, but starting in July, that should get much better because they're hiring several more that are going to be dedicated to oncology. The other thing that we didn't mention at all is there's an initiative in Rwanda called HRH, Human Resources for Health, that the Clinton Foundation is organizing, and it's a 7-year program where doctors and nurses from this country, I think from like 10 medical schools and 8 nursing schools, are recruited to go over there, and they're working in the medical schools and the nursing schools to not only increase the quality of the education, but increase the numbers of people that they can train, and that's just almost a year old. So the first cohort that have been over there are finishing the first year, and so I suspect that over the next 7 years it will be a different world over there in 7 years.
So until then, is there ever sort of a sense of to oncology?
No, I mean, I don't. We worked with other great surgical nurses, and actually, David mentioned this. The nursing education, that there's 3 levels. The A2 is really high school education. So, in our world, probably comparable to like a clinic assistant or a medical assistant. And we have on the oncology unit, I know there's at least 3 A2s. And then there's an A1, which is a 3-year, sort of like an associate's degree. And then there are A0s, and there are very few of them, and those are nurses with a bachelor's degree.
And I would say I don't think we necessarily pulled like the sort of lead nurses from the rest of the hospital. And I think relative to the other wards in the hospital, the oncology ward is still really understaffed. Even when they get 10 nurses, it will be understaffed. Just because the workload for those nurses is really different than on other wards. And it's really different than an oncology nurse would have here. It's their, the ratio of like nurses to patients there is probably 1 to 10 on bad days, 1 to 7. And then, yeah, some days 1 to 20. And then they also do all the chemo mixing and administration, a lot of tasks that might be done by other patients.
And I think the doctor aspect of it is even less well organized than the nurses. So in general, Butaro Hospital is a little bit short on doctors. It's considered by the doctors a bit of a hardship post because it's 3 hours, as she said, mostly by dirt road from Kigali. And these are young guys, they have family, they have kids, they want their kids to be able to go to school, so they want to be in Kigali. So they're up there because this is where they got the job, but they don't want to necessarily stay up there, and oncology is primarily up there, so it's a little bit of an issue. And I think that what I saw when I was there, there were maybe 3 or 4 of the docs who were interested in oncology, and they seemed to be the ones that always showed up in clinic or always showed up on rounds. And then there were others that weren't as interested that I really never got to know. So I think that as Laurie said, in July they've hired a Rwandan doc who is dedicated to oncology, and it's going to make a big difference because then he or she can just train all day. You know, they can be with us all day long, and it'll be much more rewarding for them. They don't get that much oncology in their undergrad training, so this is a frightening field to them, and chemotherapy has its own mystique and it's frightening. So I think that also, we were working to demystify that, but it has helped more education they get, the easier it is to demystify.
There are also, people are assigned by the Ministry of Health where they work, nurses and doctors.
And the government has thought about this. I mean, it's a great question. So Partners in Health doesn't give any top-ups to any of the nurses or doctors working at the hospital. Rwanda actually passed a law against that last year. So they're all actually hired by the Ministry of Health, paid by the Ministry of Health, and allocated by the Ministry of Health. So,
So the other district hospitals that are not backed by PIH, what are they like in terms of personnel and in terms of drug distribution or drug availability? Do you guys know anything about that?
yeah. So I think I went to 2 of the big tertiary hospitals in Kigali right before I left because we referred some patients there and was checking them out now. The public hospital in Kigali is extremely busy. And it is pretty understaffed and underfunded. Again, the staffing's not hugely different at these because they are allocated by the government. But a lot of them are, especially the hospitals in Kigali, are just teaming with patients. They're
2 kids to a bed, 2 or 3 kids to a bed.
Because they don't have quite the same facility, and then they're not stocked as well with supplies of drugs. So especially for cancer care, a lot of the drugs we use, it's harder for them to get. So there are some patients treated at the big hospitals in Kigali for cancer, but relatively few. And then the district hospitals in other parts of Rwanda, they're probably not really treating any patients with cancer.
Although that's where a lot of the surgery takes place at the big teaching hospitals. So, and that's where a lot of the HRH doctors are working. So we would get a lot of patients from the big teaching hospitals where they had their surgery there, and then they sent them to us for chemotherapy because we had the drugs.
Maybe you addressed this earlier on. I noticed in the class of graduating nurses there were around 20 people. Are these people reallocated by the Ministry of Health, or do they stay at Butaro in Rwanda? The nurses.
The nurses that went to our training?
Yes.
So the nurses that went to our trainings came from all over the country. So the military hospital would send 2 nurses. The Shiaska would send 3 nurses. So nurses came from all over the country to get the training. And then they went back to their, hospitals.
And just a follow-up question, when they go back to these hospitals, is there cancer care possible at these locations?
At a few of the hospitals, so I never quite understood King Faisal. So there's this other hospital, King Faisal, that's in Kigali, where private, but the ministry still has something to do with it. So they do a little bit of chemotherapy there. And there was what was that? There was another hospital that had chemotherapy. So there's a little bit happening, but not a lot.
There are 2 Rwandan oncologists in Rwanda that were trained in South Africa that we met when we were there. And they work primarily, they're in Kigali. One's at the military hospital, and Fabian is their King Faisal. And King Faisal,
The
most of
private
the patients, you have to pay for chemo, though, right? So
Yeah.
sometimes we would get them after they've been started at King Faisal, Tara, because we, you know.
What's being done to improve patients' access to pain
So I don't know the details of this, but HRH is doing a big portion on palliative care, and Eric Krakauer, who many of you might have gone to his lecture, it was part of the GO, right? when
He
we
did
were in-
the second, like, larger Go lecture
Yeah.
on access to, basically access to things like morphine and.
So it's definitely something that's high on the priority list, that I think that they will start working on more seriously. And I know